It's so exciting to be able to learn about research and new and future treatments for Parkinson's, straight from the true international experts. So I'm going to tell you a little bit about Dr. Hauser. Dr. Robert Hauser is a professor of neurology at the University of South Florida College of Medicine in Tampa. He serves as director of the USF Parkinson's Disease and Movement Disorders Center, which is a Parkinson Foundation Center of Excellence. Dr. Hauser earned a medical degree from Temple University School of Medicine in Philadelphia, and then completed neurology training at the Eastern Virginia Graduate School of Medicine in Norfolk. Dr. Hauser completed his fellowship in movement disorders at the University of South Florida, and then became the center director in 1994. He has authored or co-authored more than 300 peer-reviewed publications and is one of the world's most cited Parkinson's disease investigators. He's past chairman of the Interventional Neurology section of AAN, has served on the executive committee of the Parkinson Study Group, and was a member of the steering committee for the NIH-sponsored Neuroprotective Exploratory Trials in Parkinson's Disease Program. Dr. Hauser lectures frequently at scientific meetings and has served as the chairman of the 2009 World Federation of Neurology International Congress on Parkinson's Disease and Related Disorders. He has extensive experience in clinical trial design and execution. Outcome measures that he developed have become the gold standard for use in clinical trials. He still somehow has time to maintain an active patient practice and has been voted a top doctor by his peers every year since 1993. His primary research interest is the development of new medical and surgical treatments for Parkinson's disease and other movement disorders. So it is my extreme pleasure to welcome Dr. Hauser, and I will turn the floor over to you. Can't wait to hear what you have to share with us.
Great, thank you, Andrea, and thanks to PMD Alliance for putting this wonderful forum on today. So welcome everyone, happy afternoon or morning, depending on where you live. I was asked to speak on recent and future medications in Parkinson's disease, and let's jump into this. Let's see, how do I get to my next slide? Here we go. Okay, so a few disclaimers. A lot of times when we give lectures, we do fair balance, which means we talk about the benefit and potential side effects. To get through these, I'm not really going to talk much about side effects, so please be aware that this is not a fair balance discussion, and I also can't include all recent and future medications. I'm going to cover a lot, but not all. Note also, especially regarding questions today, I'm unable to provide individual medical advice. And of course, you should ask your individual healthcare provider about potential benefits and side effects of any medication you are considering before taking it. So that was from my legal department, which below notes substantial growth over the last quarter, producing 21% more mumbo and 17% more jumbo. These days, we also show our conflict of interest. I do a lot of consulting for various companies, especially pharmaceutical companies, so you may want to take that into account as I go through this. So what am I going to talk about today? Well, the two main topics that are highly prevalent in research. One is that we still need medications that allow patients to maintain good benefit through the day. So that'll be one topic I'll be spending a fair amount of time on. And then the other really important unmet need in Parkinson's disease is we need medications to slow, or even better yet, to stop the progression of Parkinson's disease over the years. And I'll talk a little bit about that as well. So let's just jump back to the beginning here. And I think you can see my pointer, right, Andrea? Nod yes or no? Yep. So here are the dopamine neurons depicted in red in the center of the brain. And as you all know, people in Parkinson's disease are losing those neurons. And when they do, dopamine goes down. We generally think that you need to lose about 50% of dopamine neurons. The dopamine needs to be reduced about 50% before one gets the classic motor features of Parkinson's disease. And they include slow and small movement, rigidity or stiffness, and tremor. And there is our colleague Fiona Gupta examining a patient in the picture below, and that patient has all those signs. In addition, Parkinson's disease tends to be an asymmetric disorder affecting one side more than the other. So since dopamine is low, you might think, well, let's use the medication dopamine. Well, the problem is dopamine doesn't get into the brain, so we can't use dopamine. So investigators many years ago in the 1950s and then into the 1960s developed levodopa as a treatment for Parkinson's disease. Levodopa is a precursor to dopamine, and so levodopa is the main medication in the brand medication Sinemet, and you see its molecular structure on the left there. So patients take Carbidopa, levodopa in pill form. The Carbidopa is really there to reduce nausea and allow more levodopa to get up to the brain. When a patient takes Carbidopa, levodopa, it needs to be swallowed, needs to go down the esophagus, it needs to get past the stomach, it gets absorbed in the small intestine, has to go from intestine to blood, from blood to brain, find its way into remaining dopamine neurons, and as you see here, it gets converted into dopamine, stored in little packets, and then released to provide benefit. So it's got a long journey to help patients regain function. And one of the problems we have, I mean, it works great, especially initially, but one of the problems we have is that levodopa lasts only a short time in blood. And you see that here on the left. It gets, once it's in the small intestine, it gets rapidly absorbed, but it's also rapidly cleared from the blood. And we say you typically need a level that's about way up here, about 0.9 or 1. So it really only maintains a good level in the blood for about 2 hours or so. So you may say, well, Dr. Hauser, if that's the case, if it's only maintaining a good benefit in blood for 2 hours, why is it that early in Parkinson's disease I can take it 3 times a day and the benefit is sustained from dose to dose? And the answer is that once it gets up into remaining dopamine neurons, those neurons that are left can take that levodopa, convert it to dopamine, store it, and slowly release it over time. But the problem is, as time goes on and more dopamine neurons are gone or degenerated, that storage and release capacity is reduced, so patients begin to say, geez, the medication isn't lasting as long. So here's my depiction of that. If you look in the blood, levodopa goes up and down, and even over the years, that doesn't change, but the clinical response changes dramatically. Here in early disease, patients taking it 3 times a day, but the response is maintained all through the disease. If we go out a couple of years, patients will say, I take the medication, it provides a good response, but after a couple of hours, let's say after 4 hours, my slowness, stiffness, tremor comes back because the medication is wearing off. Again, that's because that storage and release capacity is diminishing. They take their next levodopa dose, it may take like a half an hour to kick in, lasts a couple hours, and then wears off. And then as the years go on, patients may say it takes even longer to kick in. It may take 40 minutes to kick in. And then now patients may get dyskinesia, twisting, turning movements, and then it wears off. And now as patients move on in years, it may last only 3.5 hours, then 3 hours, and then slowly it may last only 2 hours or so. So over time, patients find that that levodopa effect lasts a shorter and shorter amount of time. So one issue is the brain is unable to store and release dopamine from levodopa as well, or make it last as long. The other problem is that this journey that I described, it's got to get through the stomach and into the small bowel to get absorbed. Well, the nerves to the stomach are not functioning as well. So pills, once you take them, they can get caught up in the stomach. It takes a longer time to get through the stomach, so patients find it's more erratic for the pills as far as when they start to work and kick in, and it also takes a longer time. So those two components, the brain not being able to make the levodopa convert to dopamine and have it released over a longer time, and the stomach being slower in its effect, those two things contribute to patients developing wearing off periods and having more off time through the course of the disease. So this gets back to my issue. How do we provide patients good benefit through the day more consistently? So I'm going to talk about a few medications that either have come out recently or we're developing for future use to try and solve that problem. I just thought I'd mention before I get into that one of the hot topics that we and others are involved in are so-called wearables, ways to objectively monitor how patients are doing through the day. One that we're involved a lot is called PKG. It's from Global Kinetics. It's a wrist monitor that patients wear, and it gives us a printout. In blue, we see how much movement a person's having. This tells us how much slowness or bradykinesia a patient's having. And way down the bottom here, let's see if I can get my pointer back. This shows a patient takes their levodopa, they get a good benefit, they're moving well, and then the benefit wears off when it comes time for the next dose. They get benefit again, the benefit's maintained. Here's another period where they get slow again. So we can see how they're doing through the day. And up in green here, this is dyskinesia. You can see with their first dose, they don't get much dyskinesia, but the second dose, they get a lot of dyskinesia. So this is being developed to help us gain more information about how a patient is doing through the day. And of course, our goal is to minimize dyskinesia, to bring this green line down and to get this blue line up to help patients move more normally through the day. So I think this is going to see more use in clinical practice and help us develop these medications to get a better response through the day. All right, so let's move on to medications. So if the problem is that levodopa in pill form is rapidly absorbed and then rapidly cleared, one obvious idea is, well, can we deliver it in a more consistent fashion through the day? And the answer is yes. Here's one solution. This is often known as a levodopa pump. This takes the carbidopa levodopa and puts it in a suspension. This black thing down here is a cartridge. It contains the carbidopa levodopa. It's placed in this pump. The patient gets a tube placed through the abdominal wall with the tip being placed through the stomach and then down into the small intestine. So this product delivers carbidopa levodopa into the small intestine. The pump runs all day long, and it's very good to provide carbidopa levodopa into the system all through the day. The problems, as you might imagine, is you've got to carry around this pump all day long. It does require surgery, and there is this tube through the abdominal wall. And tubes have inherent problems. Tubes can potentially get blocked up. They can become dyskinetic, etc. So although this solution is very good on the benefit part, it does require a fair amount of maintenance, and you've got to be ready to put up with those potential negatives. But it is highly effective for patients who want and are able to put up with those negatives. So a lot of thought is being put into, well, are there easier ways to deliver carbidopa levodopa into the system, into the bloodstream on a more consistent basis? And one idea is, can we use a pump to pump it not through the abdominal wall and through the GI system, but just could we get it under the skin where it could then get absorbed into the bloodstream? So this is a product from a company called Neuroderm. It's an infusion under the skin. So it's called a subcutaneous infusion. Their new pumps look something like this. So each morning, the patient has to attach a little carbidopa levodopa solution, and they have to put a little needle under the skin, and then through the day, the pump pumps carbidopa levodopa under the skin. So this is in development, and if on my slides you look in the upper right-hand corner, I've listed the status of each of these. The GI pump I just showed is available. This pump for under the skin use is in development. So the issues for this under the skin pump are, can we really get enough carbidopa levodopa so it can replace a person's cinnamon? It looks like maybe not. It looks like you can only get enough under the skin to add on to an oral regimen, but it may be able to smooth things out substantially, and clinical trials are underway to evaluate that now. There's also the issue of how irritating or problematic is delivering carbidopa levodopa under the skin. Some patients may get little nodules. That may not be too difficult to overcome, and some patients get some hemorrhaging at the site where these needles are placed. And again, we'll see how troublesome that is, but there's a lot of interest in this therapy, and we'll see how that turns out in clinical trials that are ongoing. What about pills? You would think it'd be pretty easy to develop a long-acting pill. We think we hear about long-acting pills for all sorts of other medications all the time, but it's just not so easy with carbidopa levodopa because it's not absorbed in the stomach. And what happens is once it gets past the stomach, it slips through the small intestine pretty quickly, so it's not as easy as with other medications. Well, the extended-release medication that is available is called Rytary. It is FDA approved and available. So this is a capsule that contains little beads of carbidopa levodopa. A third of them are immediate release and 2/3 of them are extended release. So in the blood, it looks like this. The regular immediate release pill, little beads get absorbed right away and rapidly cleared. But the slow release ones do take a little longer time to get absorbed, and then they get more absorbed over time, so that they provide this long-acting benefit. So these pills do last longer. There is an issue with regard to dosing. The doctor who's giving these has to understand how you do the dosing. If we talk about a typical dose of regular Sinemet, 100, it kind of looks like this gray line here. It goes up and down. 100 of the Rytary goes up only a third of the way, but does last longer. So the doctor has to understand you need to give about 3 times as much to get to the same peak, but it does last longer. So the doctor has to convert the patient over based on knowledge of the dosing. And then there's an adjustment period because although we have an idea how to do the dosing conversion, a lot of people need a little bit more or a little bit less after the conversion. So what I say to patients is if we're going to convert over to this long-acting capsule, you have to be prepared to go on a journey. I'll pick the conversion, we'll try it, and then you have to be prepared that I could underdose or overdose. If it's too little, you may have slowness, stiffness, tremor, then we got to go up. If I overdose, you may have dyskinesia or some other side effect, then we got to go down. So you've got to be ready and prepared to make adjustments once we convert over. And from the studies I've shown on the right here is that patients who are having off time, motor fluctuations on regular Sinemet, when we convert over to Rytary, they get about an hour, a little more than an hour reduction in off time. But at the same time, they can go from 5 Sinemet a day down to about 3.5 of the Rytary. So a lot of patients on 5 Sinemet can go down to 4 Rytary per day and have less off time. So it's a medication we use here at our center quite a bit for patients who are having off time or motor fluctuations. A medication that recently had a setback, but I think portrays a lot about what we're thinking, is the Accordion pill. This is from Intech Pharmaceuticals. In this medication, the developer has put carbidopa levodopa on a film structure, and on this film, what they do is they fold it up into an accordion-like structure. They put it in a capsule. When the patient takes this capsule, the capsule dissolves in the stomach, and the film unfolds, and the film sits in the stomach, and the carbidopa levodopa the carbidopa levodopa then goes from the stomach down into the small intestine over about 10 hours or so. We completed a recent clinical trial, and we didn't see better benefit with the Accordion pill than Sinemet, but the Accordion pill was given much fewer times per day than the Sinemet. So I think we're going to hear more about this pill in the future with a different design in clinical trials. It looks to me like it does deliver carbidopa levodopa over a significantly longer time than regular Sinemet. Okay. Now, the next two are different kinds of medication. Rather than trying to provide levodopa through the day, these are treatments on demand or as needed treatments for patients when they go into off periods. And the one that's recently been approved is called Inbrija. This is an inhaled formulation of levodopa. It's called an orally inhaled because you take this little device, you put a capsule of Inbrija in the device, and then when you start to turn off, that is when symptoms of Parkinson start to come back, when the slowness, stiffness, tremor starts to come back, you take an inhalation, and the levodopa is delivered down into the lungs, and the levodopa is absorbed from the lungs into the blood, and then it goes up to the brain. And you can see that the potential benefit is that the levodopa is freed from the GI journey. It doesn't have to go down the esophagus, get through the stomach to get to the small intestine and get absorbed into the blood. it goes directly from the lungs into the blood. So this is now FDA approved, and for patients who are having off episodes, you may want to speak to your physician as to whether this might be a reasonable medication to try. Along those same lines is another medication that's called sublingual apomorphine. Apomorphine is different from levodopa. It's a medication that looks like dopamine, so it's called a dopamine agonist, but it's the most effective dopamine agonist we have. It's a short-acting dopamine agonist. There is out and available an injection of apomorphine, but this is different. It's on a film that you see here on the left, and what patients do is they put it under the tongue, and it's absorbed directly through the mouth membranes into the bloodstream to get up to the brain. And this is in clinical trials. The data is in front of the FDA, and we'll see if that gets FDA approval. So that it might be an alternative to Inbrija, and we'll see if that does get approved by the FDA. Now, yesterday we had another medication approved. It's called Istradefylline. Istradefylline is a medication that we add on to patients when they're on carbidopa, levodopa, and having these fluctuations to reduce off time. Its claim to fame is a non-dopamine medication, so the studies have shown that it has fewer side effects attributable to dopamine. It looks like it may cause less nausea, less lowering of blood pressure, less sleepiness, less compulsive behavior than traditional dopamine-type medications that we use. So studies demonstrated that in a patient on carbidopa, levodopa, if we add it on, we get a reduction in off time with less side effects than many of the other dopamine medications. On the left, it's not important that you know the details, but it just demonstrates that it doesn't act on dopamine itself, but it does act on the basal ganglia circuitry, and we talk about it as it releasing the brake, because when dopamine is low, we get a braking effect from adenosine, and it releases the brake from that adenosine causes. There's another category of drug called COMT inhibitor. There's one that's in development called Opicapone. It's a once-a-day medication. Out and available is a medication called Anticapone, which is a COMT inhibitor that's given with each carbidopa, levodopa. Opicapone is a once-a-day COMT inhibitor, and what these COMT inhibitors do is they send more levodopa up to the brain over a longer time. Opicapone is a once-a-day, so that's its main claim to fame. Information about Opicapone is in front of the FDA now, so you may hear more about it in the next several months. Okay, so one cool little thing that I'll mention is a gene therapy. People are always interested in gene therapy. And remember I showed you that when levodopa gets up to the brain, it needs to be converted to dopamine, and the gene that does it, or the enzyme that does it, is AADC, or aromatic acid decarboxylase. One of the problems in the brain is that over time in Parkinson's disease, there's less of this AADC to convert levodopa to dopamine. So this company has the notion that if we can increase that enzyme, we can make the levodopa that gets up to the brain more efficient. We can convert more of it to dopamine. So what they do is they deliver in a virus the gene for AADC into the brain, and it's a small, sort of an injection type surgery, and they deliver that gene. More of this enzyme is produced in the brain, and what their preliminary information is showing is that then patients on levodopa get better response through the day with less off time. So that's in clinical trials, and we'll see how that progresses. One little different kind of medication that recently came out is Gocovri. Gocovri is a long-acting amantadine. This is the one medication that's approved for the treatment of dyskinesia. Gocovri is kind of neat because it's given at nighttime. When you're sleeping, it gets absorbed and slowly goes up. So it's available first thing in the morning when you wake up, and then slowly goes down through the day. It rather substantially reduced dyskinesia. Interestingly, it also reduced off time. With this medication, there is a pretty high incidence of hallucinations, so it's not for patients who already have hallucinations or who have reduced kidney function. But for those who are having dyskinesia that's causing a problem, this is a potential medication they should discuss with their medical physicians. Okay, so I'm going to talk about a different topic now, which is slowing progression of disease. And so many of us have realized that the big problem that we face is that over time, we've got problems. When you look 15 years out from diagnosis, about 84% of patients have cognitive decline, 50% have dementia, and 80% are experiencing falls. And it's going to be really hard, I think, to come up with medications to symptomatically treat these things in a very substantial way. So the way we need to get at these things is to slow disease progression. If we can slow disease progression 50%, and these aren't problems for 30 years instead of 15 years, we'll really be making some progress. So how do we do this? Well, in the last 5 to 7 years or so, I think it's become clear, at least I think it's clear, that at the heart of Parkinson's disease is this protein clumping process. And we have a protein in our brains called alpha-synuclein that in Parkinson's disease appears to misfold. And when it folds in this certain abnormal way, it allows it to clump up, as you see here. And once you start this clumping process, it recruits the clumping of other synuclein molecules, and this process just goes on. And here's what it actually looks like. Here's an actual synuclein molecule. And when they misfold and clump up, it looks like this. It goes from sort of a, what we call a helix, sort of a spirally shaped molecule, into a sheet. So this is what the clumps actually look like. And when you take a whole bunch of brains with Parkinson's disease at various stages and look to see where do you see these clumps, the brains with the least clumps, you see the clumping down at the bottom of the brain, and those with the most clumps, you see what appears that the clumping process goes up the brain and then up and over it. And that makes a lot of sense because up here at the top is where thinking and memory are, so that's a late process. Similarly, balances in the back of the brain, that's a late process. So the notion is, can we detect Parkinson's disease early on, maybe even before people have slowness, stiffness, tremor, and apply an intervention to slow or stop this progression of the clumping process. And one of the things we see is that here's another depiction of clumping. A key part of that, though, is when you get a little clump in one neuron, these little clumps can move from neuron to neuron and start that process in the next neuron. And that's the way this process moves through the brain. So researchers are thinking, how do we interfere with this process? Well, one way we might do it is to have the brain make less of this protein, make less alpha-synuclein. Another way is to say, can we stop the alpha-synuclein from clumping up? To me, that's a very, very important thing. Can we take the clumps that are being formed and clear them out? Can we make it so that those clumps aren't causing problems for the neuron, or can we make it so that these clumps don't move from neuron to neuron? And probably the most advanced therapy right now are antibodies made against synuclein that we can deliver to patients. And the way these are thought to work, these antibodies actually attach to little clumps of synuclein as they're moving from one neuron to the next. So you see, here's where a little clump would move to the next neuron and start the process in the next neuron. And these antibodies would attach to a little clump and make it so that it can't move to the next neuron and help clear out little clumps. So there are two of these studies currently ongoing right now. One is by Roche, one is by Biogen. And the way these studies work is that patients with very early disease come into the study, they're not on any symptom medications, and we can monitor how much slowness, stiffness, tremor they have over 9 to 12 months. So we can write down numbers for that, and we can numeritize or put numbers on the progression. When patients come into the study, they get randomized to receive either the antibodies or placebo for the antibodies. And then once all the patients are through the study, the computers will do an analysis and tell us, did the patients who received the antibodies experience slower progression over 9 to 12 months compared to patients who received placebo. So we should get readouts on these two studies in the next year or so, so we're all anxiously awaiting that. Now, negatives are, it's not clear how much of these antibodies actually get into the brain, and how well they'll work. In animal models of Parkinson's disease, it looks like they work quite well. How well they work in patients, we'll see. But this is really the first attempt to attack what I think is the core of Parkinson's disease, so it'll be an important readout. My opinion is, even if it's negative, this is still an exciting area of research. I'm particularly excited about this. This is about the notion of how do we prevent these synuclein misfolded molecules from clumping up and causing the problem in the first place. And you see over here on the left, these are the synuclein molecules starting to form these sheets. And what one lab has done, this is a lab from UCLA, and this is a product that's now licensed by a company called Selos. They've made these gray peptide molecules, and they designed them so that they bind on to these little tiny clumps when they first start, and they make it so that these little clumps can't grow into larger clumps. So these are basically clumping inhibitors. So far this has only been tested in petri dishes, so to speak, but it prevents this clumping process from proceeding forward. And we're now working on evaluating these peptides in animal models of Parkinson's disease to see, can we get them into the brain, and can we prevent this clumping process from moving forward in the brain. So I'm very excited about this kind of therapy. There are other companies that have similar therapies that appear to be able to prevent this clumping in models of Parkinson's disease. So I think this is very exciting, and we'll see how far it progresses. So that's what I wanted to say today. I hope I brought you some good information. We talked about new and in development medications to help try and maintain good benefit through the day. I also gave you a little bit of a view about medications in development to slow or perhaps one day stop the progression of the disease. So thank you for listening, and we'll open it up to questions. Thank you, guys.
Thanks, Dr. Hauser. I liked a lot of those visuals too. That helped explain some of those concepts that I've heard people talk about. So great visuals.
Thank you.
Your first question's from Mark. He would like to know about animal models of PD. He's heard specifically that rats do not show changes with MPTP, and is wondering how genetic models of PD are created. That's a doozy of a first question. What do you got for us?
Yeah. So for many years, scientists used toxic models. MPTP was one of the favorites. When you give an animal MPTP, it kills a bunch of dopamine neurons. And those were very good models to test symptom medications, because the animals would lose dopamine neurons, they'd have low dopamine levels, and you could give them things like Levodopa or dopamine agonists, and they were very predictive for symptom medications. The problem is they were very poor predictors of things to slow progression of disease, and you could imagine why. They didn't really recapitulate the problem of Parkinson's disease, or the process, the underlying disease process of Parkinson's disease. So it's only been in the last couple of years that scientists have been able to develop these genetic-based animal models of Parkinson's disease, where they deliver the genes to animals and then breed them so that they express the abnormal gene, and then the process goes on within the models. So these animals, for example, can overexpress alpha-synuclein. Some of the models just have too much alpha-synuclein. Others have a gene mutation that is equivalent to what a patient might have. And there are various mutations that we know that can cause Parkinson's disease. Now, one of the problems that we face is none of the models is perfect, and you'll hear that debated among experts all the time. Oh, the pathology isn't exactly the same. Oh, the clinical symptoms aren't exactly the same. And that is true, but I think we're light years ahead of where we were with regard to using these models to develop things to intervene and slow Parkinson's disease compared to the MPTP model, because now we're getting at the core of the disease. we're looking at models that have the same etiology, whether it's an alpha-synuclein-based model or one of the other mutation models. These are things that we know in people really cause the disease. So I think this is, again, a huge advance forward. And, you know, if I'm an investor, what I say to a company is, show me that it works in an animal model before we test it in patients, and that's the way we move forward.
Very good. And I'll remind our viewers, if you'd like to unmute yourself and ask a question, this is now the portion of the program where you can do that. Just give us a little wave. For example, I think I see, is it El Bruno AZ?
Yes.
Yeah, go ahead with your question, sir.
Yes, I've had Parkinson's for a long time. It's getting towards the Parkinson's for me, I guess. But about this fecal transplants that they're doing with the mice, they're transferring Parkinson's from the fecal transplant of a human.
I'm sorry, you're going in and out.
Okay.
Yeah. Could you ask your question again? I think it was about fecal transplants in mice.
Yes. Fecal
fecal transplants.
Yes. From and they develop Parkinson's.
Right. So fecal transplants. So there's a huge interest these days in gut-brain interrelationships. And probably the study that you're talking about, the investigators looked at a synuclein model of mice, and when they bred them in a bacteria-free environment, there was very little Parkinson's disease pathology that occurred in the mouse. When they raised the mouse in a normal bacterial environment, there was regular old Parkinson's disease pathology in the mouse. And when they gave the mouse a fecal transplant from a Parkinson's disease patient, there was increased Parkinson's disease pathology. And so researchers are looking at what is happening in the microbiome, which just means the bacteria that live in the gut. What processes could be going on based on those bacteria that could be influencing the, in this case, mouse, but in the future, patient's system to push forward the Parkinson's disease itself in people, mice or people, who have a predisposition. So this is a very hot area of research. I think what's going to happen is that researchers are going to try to isolate, well, which bacteria are associated with an effect, what particular metabolic processes associated with those bacteria are associated with that, and then what happens if we stop or inhibit those processes or bacteria. What can we do will we see improvement in Parkinson's disease patients if we inhibit those processes? So this is a very active area of research.
Very good. And I think next, if we could go to Arthur. Did you have a question, Arthur Porter?
Yes, I did. Thank you. Does Parkinson's ever affect the diaphragm, causing breathing problems?
Okay, so the question is, does Parkinson's disease affect the diaphragm? And the answer is yes. It can affect the diaphragm in a couple of ways. The way that jumps into my mind is there's one thing called diaphragmatic dyskinesia. So I mentioned dyskinesia a little bit. That typically happens when dopamine is high, when levodopa is peaking, and often people get twisting, turning movements. But you can also get abnormal movements when levodopa and dopamine are going up or down. And just like with body movements, like in the head or arms, you get twisting, turning. The same thing can happen to the diaphragm, which is the layer under the lungs that's responsible for breathing. Normally it goes down to help us breathe in, goes up to help us breathe out. And so you can potentially get these abnormal, I'll call it fluttery movements in the diaphragm that are part of dyskinesia when levodopa is either peaking and dopamine is high, or potentially, and less commonly, going up or down. So that's one answer. And some patients, when levodopa and dopamine are down, can have problems breathing just because of restrictions of movement in the chest cavity and diaphragm. So all those are different ways that one can see breathing problems related to where they are in the Parkinson's and levodopa cycle.
Thanks. Our next question is a different, somewhat of a different perspective, but really interesting. So I want to pass it along. So Anne says, there seems like there's been a lot of research breakthroughs in the last decade or so from your generation of researchers. She wants to know if there's a next generation of young scientists in the pipeline to take up the mantle and keep up the level of advancement. So from where you sit, are you working with a lot of young researchers?
Yeah, definitely. There's a lot of young researchers coming up now. You know, I will say that, you know, I've been saying for a long time, we're trying to close one chapter, which I kind of went through today, which is this symptomatic therapy, maintaining symptomatic therapy through the day, and we've made decent progress on that. We've got Rytary, there's more long-acting medications and infusions coming, so I think we're making good progress there. But the new chapter is slowing progression of disease, and this whole synuclein story, the mutations that we know, and ultimately getting to slowing and stopping disease, that's the new chapter. And yeah, if you're calling me the old generation, we've sort of opened the book, and I sure would like to be around for when we close it. But yeah, there's a lot of young men and women coming up behind us who are going to help us and carry that forward.
Very good. Oh, that's always bad when we call our expert speaker old, huh? You handled that very gracefully.
Thank you.
Let's see. Next, Surette.
Yes.
Forgive me if I'm mispronouncing that, but I think you have a question if you want to go ahead.
Yes, I do, and your name is correct. I'm interested in vitamin B1 thiamine megadose therapy as developed by Dr. Constantini in Italy. Do you have any experience or impression?
Yeah, no, I'm sorry, I can't comment on that. I don't know enough about it.
And I think that brings up a good, maybe an overall question. When our audience sees a press release or an article on the internet about, you know, whether it's a vitamin or something in the pipeline, how do you advise us as non-scientists, lay people, to deal with the almost constant barrage of news stories about, you know, the miracle cure or the newest molecule or the alternative medicine?
Yeah, this is a really tough one. Of course, I grew up in the days before the internet, and we didn't have all this. And the first thing to recognize is there's a lot of legitimate science out there that gets communicated over the internet that people like me, and I think I know a lot and try to keep up. I just can't know everything that's in the labs all around the country that's being tested in animals, for example. So there's a lot of very good, exciting work. I just can't know it all, and that doesn't mean you should dismiss it. But you also should recognize that a lot of the stuff in animals is very preliminary. It may or may not turn out to work out well. It may or may not end up being associated with side effects, and you just can't get ahead of yourself. It's good to be interested. It's good to be knowledgeable, but I really wouldn't do anything based on, you know, a study I read on the internet without getting endorsement from your doctor or an expert about it. So there might be something great, you know, in this example about B1, but you'd have to investigate, you know, where is it in its development? Has it been tested in a good placebo-controlled, prospective placebo-controlled clinical trial? What do we know about its benefits and side effects before you can get serious about you taking it? That's a little separate than, you know, being interested in the knowledge base. Now, separate from that is there's a lot of people out there who, you know, want to make money off of people with just pulling strands of a little bit of, let's say, thoughts that are outside the mainstream, a little bit of quackery, et cetera. And it's really hard for people these days to know the difference between legitimate science and things that are just crazy. And, you know, sometimes it's easy, you know, if it comes from a university, if it talks about animal studies, that's usually pretty good. But it's become harder and harder to differentiate the two. So again, I think you got to ask your doctor, you got to ask experts. But by the same token, I don't know all the studies that are early on, and I don't think anybody can. So I guess that's the best I can say.
Okay. Bill added a comment that he always looks for the N equal, and that sometimes these news stories are about a study on 5 people. That's a valid comment, right, Dr. Hauser?
Yeah, I think when things get that far out, when things get tested in Parkinson's disease patients, early on, they may get tested in a small number of patients and what's called open label. Open label means everybody got the real thing. And what that's missing is a placebo control group. And the problem is I can take essentially anything and test it in a small number of patients. And if I don't have a placebo control group, a group that's getting what looks to be the same thing, that I can see what happens, everything shows improvement. You know, I can take water, I can take, you know, sugar pill, everybody improves open label. So I think a lot about, should we even do open label studies? I try to convince people, even if you're going to do a small early study, try to use a placebo control group. Now, people don't like to do that because what happens then is a lot of things turn out negative, and then that's the end of it. The usual in science is you do a small open label study, it shows a good effect, and then you move forward, and it's not till later on that you're doing a double-blind, placebo-controlled study, and that's where you say, geez, guess it didn't work after all. But yeah, I wouldn't get too excited about things where there's a small number of patients or open label without a placebo control group. You know, I spent a fair amount of time. It's a lot harder when we're talking about things that are really early in animals. You know, I think you can't get too excited about things in animals because they have yet to be developed.
Very good. Now to go from that general to a specific question, I have in the chat, I have tremor dominant medication resistant PD that has been very successfully treated with STN DBS. What does this indicate with respect to the areas of the brain that are involved? That's something that you can comment on without knowing, you know, his full chart.
So it's tremor dominant Parkinson's disease. Yeah, so, you know, I'm not a big fan of calling things tremor dominant and tremor non-dominant. There have been studies that show that if you use the characteristics that define those things, patients can move from category to category. Nonetheless, you know, I did a study when I first started just trying to figure out how to do research, and I asked patients, what aspect of your Parkinson's disease is causing you the greatest difficulty? And then I divided it up by years since diagnosis. And for the first 10 years, the number one answer was tremor. And I submitted this information to the American Academy of Neurology. I got this big presentation. I was a young guy. I didn't know that it was hard to get those presentations and what this meant. And I presented it, and all the big important docs came up and lined up to tell me why I was wrong. The tremor is not a problem, doesn't interfere with function, et cetera, et cetera. Well, the truth is we don't have good treatments for tremor, and patients really don't like tremor. So I was right, and I got a bit intimidated when all these experts told me why I was wrong. And I always warn patients with Parkinson's disease when we start them on medication. I say, for example, Levodopa usually helps slow and small movement pretty well and stiffness pretty well. But for tremor, it's a wild card. Sometimes it helps tremor great. Sometimes it helps it partially. A lot of times it doesn't help tremor at all. And it's really not well known why that is. I've heard theories that it has to do with differences in why various people have tremor and whether it's due to circuitry related to basal ganglia or cerebellum. And there's some information that suggests that's the case. So Levodopa may or may not, and other traditional Parkinson's disease oral medication may help tremor, it may not. On the other hand, there's a relay circuit regarding tremor that these deep brain stimulation surgeries often do get benefit, whether it's in the thalamus, you may have heard of thalamic deep brain stimulation, or STN or GPI stimulation. All of them seem to do a pretty darn good job for tremor. And it's just because they get right to the circuit that's involved in tremor, whereas it seems like these medications may or may not hit that circuit. So that's what I have to say about that. But I've tried to emphasize to companies that make these medications, we really would like good medications for tremor in Parkinson's disease, and finally a couple are being tested for tremor.
Very good. I have a general question for you. So when I was reading your bio, you made a point to point out that you still see patients, and
Yeah.
I just wondered if you could talk about the role of, being a clinician researcher, and why have you decided to keep seeing patients, and why haven't you just, nose down, gone all in to the research side of your job?
Right. Well, the research I do is predominantly clinical research, so that's research with patients. And I do a lot of consulting with pharmaceutical companies. They often invite me to look at medications that they're testing in animals, and I try and help them put that in perspective. How big is the unmet need? How would you design studies to test that in patients? So I find there's a great advantage in still seeing patients. Number one, you understand what is troubling patients. What are they saying? Hey, doc, here's my problem. And I understand, because pharmaceutical companies will come to me and they'll say, oh, we've got a great treatment for X. And I may say, geez, X isn't a problem. We've got 10 good treatments for X. Or I haven't heard a patient complain of X in the last year. I don't know if you should really spend $50 million to develop it for X. And I may say, on the other hand, hey, look, in this animal, I think it may help Y. And Y is something I hear patients complain about every day. In addition, it helps me understand what kind of research patients are willing to donate their time and effort to get involved in. And of course, it's no sense having a clinical trial to test the medication if patients aren't willing to donate their time and effort to get involved in that research. So I think all those things are really important.
Very good. I think to lay people, sometimes when we hear research, we think of, lab coats and beakers, and not an exam room with patients.
Right.
So
that's right. I'm not in a lab with test tubes or with animals. I do look at that information. The research I do is in the office with patients, where typically patients are volunteering their time and effort to get involved in clinical research, where they're taking pills, where they may be on the real thing or placebo, what I call fake, so we can judge what are the benefits of that medication and what are the side effects of that medication. And that's what we need to show to develop and get FDA to approve or not approve a medication. And by the way, it's just as important to show that a medication we're interested in doesn't work, because if it doesn't work, we want to find out, put it aside, and move on. So thanks to everybody who's participated in clinical trials.
yes, and that is important. You literally couldn't do your job without people volunteering their time. And
that's right.
And we're always big proponents of using tools like Fox Trial Finder, clinicaltrials.gov, to see what you might be a candidate for. And those
That's
of
right.
you who are in exercise groups or support groups, and last time I spoke with you, Dr. Hauser, that trial that you mentioned in your PowerPoint, where you're looking for people who haven't had any treatment yet, as I understand it, it's hard to find those people, right? So.
Yeah, so it's almost a catch-22, because a lot of the trials that are looking at medications that we're excited about that we think might slow progression of Parkinson's disease, we're looking for patients right when they're first diagnosed, because those are the ones that we can monitor for 9 to 12 months before they need symptom medication. But two things happen that make it hard. Number one, patient might not show up in our office until they reach the point where they need symptom medication. So they'll come in and they'll say, hey, doc, I need symptomatic medication because I'm slow and I'm stiff and I have tremor and I want and need treatment. Well, they can't participate in that study. The other thing that'll happen is they'll go to their local neurologist. The local neurologist will say, hey, you've got a little tiny bit of tremor. You've got Parkinson's disease. Let's put you on levodopa. Once that happens, they're not candidates for those clinical trials either. So I'm trying to get the word out to potential patients. As soon as you're diagnosed or someone thinks you might have Parkinson's disease, think about how do you get information about these clinical trials? How do you get involved before somebody puts you on levodopa or other symptom medication, and before the time goes by that you've sort of wasted that, what I call the golden year, to get involved in research, and then you need symptom medication to do well. So it's a real catch-22 that I'm trying to think of ways to overcome.
And I think all of you out there listening, you know, that's what can I do to help Parkinson's research? That's a huge one. So you're out there, you're meeting more people than, you know, Dr. Hauser is, who are newly diagnosed or not yet taking medication, and those are crucial. So yes, identify them, connect them with us. We're happy to be the go-between, but it's very hard to find those people. So that's what you can do. So I have one last question because we're coming close up to our closing time. Okay. So Frank asks about clinical trials that are in phase 2 and 3 that have shown they have efficacy for PD. The repurposed drugs, and I might mispronounce these, exenatide and nilotinib fall in this category. 5 years have gone by since these drugs were identified. When are we going to see neurologists start to prescribe these drugs, even if it's off-label?
Wow. Okay. So these are two categories of drugs for which there is interest. Now, let's start with nilotinib. Nilotinib looks good so far in some animal studies. In patients, there's a big controversy as to whether it actually gets into the brain or not. There was a smallish open label, which means everybody got the real thing, study done in Parkinson's disease that also included some non-Parkinson's disease patients, done out of Georgetown, where they described benefit. But remember what I said, when you just give something to people and there's no control to compare to placebo, it's impossible to know whether you're seeing real benefit due to the drug or not. So the next step is you got to do a controlled trial comparing the medication you're interested in against a placebo. So there are actually two large trials ongoing now comparing nilotinib to placebo, one out of Georgetown and one being sponsored by the Michael J. Fox Foundation. So we'll see. If those are positive, we expect patients will go on them. If they're negative, then it'll be in the category of it didn't work, we need to move on. I will say there are many companies interested in nilotinib-type drugs that appear to have better qualities. They appear to have more effect and appear to get into the brain better. So this is going to be a story that's going to go on for some time, in my opinion. Nilotinib itself, we do get requests from patients to say, hey, doc, put me on nilotinib based on, I can't remember how many patients it was, 16 patients at Georgetown described that, you know, they got some benefit. Well, it's problematic because nilotinib is known to have some very serious side effects. And how do you interpret that Georgetown study? Well, unfortunately, since there was no control group, I think we can't interpret the benefit that they described. We don't know if there was benefit or not, and it has known serious side effects. So my personal position is I got to wait until I see more evidence that it potentially will help people before I prescribe it. So that's the nilotinib story. Exenatide, a glucagon-like peptide type 1. Again, there's interest. There's one study that did use some controls, but it was a very, I'll call it weirdly designed study. What they did was they stopped patients' medication and looked at them the next day and said, when you look at them the next day off medication, they seem to be doing better. But there were lots of weird things in it, and part of my interpretation is when you actually look at how patients were doing on medication, they weren't any different. When you look at quality of life, they weren't any different. So the evidence that they were slowing disease, I think, is better with exenatide and other medications of its type. So in science, you sort of need to get enough evidence to convince enough people that there's a consensus that something works. And, certainly FDA hasn't agreed that it's a medication that might slow progression of Parkinson's disease. It's certainly not approved for that. And there's certainly not a consensus among experts that the evidence that we have now is sufficient. So, I think that it's reasonable to say we need more evidence and more studies to show it is or isn't something that slows progression of disease. And it's not something that's part of this talk. Maybe PMD Alliance will want to get another talk in the future about how do we do studies to demonstrate that we're slowing progression of disease. It's not easy. And it's one of the challenges that we face. So I think I'll leave it there.
That's great. Yeah, it's a great idea for a topic, because it's so easy for us to read these news stories, and those journalists really do, their job is to simplify it and make it compelling, but the science can be much more complex. So we'll stay in touch with you, and maybe if the audience out there would be interested in kind of seeing how the sausage is made, and how researchers put together a clinical trial, we might be reaching out to you, Dr. Hauser, for to schedule an additional program. So
that sounds great.
Yeah. Well, thank you again for donating your valuable time and your expertise. And I always like to close our online programs by getting a chance to have everyone look in their video camera. We can get, a little bit of long distance eye contact. And those of you maybe who have your cameras off, if you could turn them on. And what do you think, by a show of hands, did we learn something from Dr. Hauser and all the, everything that's going on behind the scenes? Yeah? Okay. I see a lot of gesticulating. So, and I don't think they're being dyskinetic. I think that, yes, we learned a lot of great stuff. So
great. I appreciate that, everyone. Thank you.
Yeah. Thank you for tuning in and sharing your energy. This was, high level. Some of those diagrams we really had to think through, but thank you to everyone. Bye now.
Thanks, everybody. Appreciate it.